A very good day to one and all. I am Dr. Rohit Gopinath, and today we'll be discussing about abdominal tuberculosis. Now, tuberculosis can be said to be an ubiquitous condition. It affects all parts of the human body, and among the different parts of the human body which can get affected by tuberculosis is the abdomen. Abdominal tuberculosis is in fact the sixth most common type of extrapulmonary tuberculosis. Abdominal tuberculosis is generally said to be a disease of the immunosuppressed. It is very common among individuals who have been inflicted with HIV, and it is also common among individuals who have malignancies, other malignancies, any malignancy in fact, who are on immunomodulation or immunosuppression. But it is to be noted that just because it is more common among the immunosuppressed, it does not mean that it cannot occur in the immunocompetent. Even individuals with a good healthy immune system can get affected by abdominal tuberculosis because there are other mechanisms based on which they can get affected. Abdominal tuberculosis can be subdivided based on the area of the abdomen that is infected. So you can have intestinal abdominal tuberculosis, in which the ileocecal junction is most commonly involved. This is further subdivided as ulcerative type, hyperplastic type, and ulcerohyperplastic type. Among these three, ulcerative type forms 60% of cases of intestinal tuberculosis. We can also have peritoneal involvement, in which case it can be again subdivided as acute and chronic. Chronic peritoneal tuberculosis is again divided into ascitic type, encysted type, or encysted type is also called loculated type, plastic type, and purulent type. So, plastic type is the classical cocoon abdomen that we get. You can have tuberculosis of the mesentery, you can have tuberculosis of the anorectosigmoidal region, miliary tuberculosis involving the solid organs, you can have tuberculosis of the omentum. Now, there are different modes by which this tuberculosis comes to lie in the abdominal cavity. So, the modes of spread of tuberculosis can be either by ingestion, and this ingestion can be either direct ingestion of a food substance which is contaminated by the mycobacterium, or it can be because of ingestion of sputum, of the patient's own sputum, which is contaminated with tubercle bacilli. So, most common method by which you can ingest some contaminated food particle containing mycobacterium is by ingesting contaminated milk. So, the most common mycobacterium subtype which can be present in contaminated milk is Mycobacterium bovi. So, ingestion of milk which is contaminated, it can be one of the methods by which you can develop abdominal tuberculosis. And the sputum, if a patient has a primary pulmonary tuberculosis foci and he is bringing out a lot of sputum, he can sometimes swallow that sputum, and this swallowed sputum can again result in abdominal tuberculosis. Now, tuberculosis of the abdomen can also occur by hematogenous spread. When you have tuberculosis involving the lungs, you can have miliary tuberculosis, which is nothing but disseminated tuberculosis, where every other part of the body can get affected, including the abdomen. From the neck nodes via the lymphatics, also you can have abdominal tuberculosis occurring. Now, there is an entity called a retrograde tuberculosis, wherein you can have retrograde infection of the abdomen peritoneal cavity through the fallopian tubes. So, that has also been documented, and you can have direct spread. Let's first discuss about ileocecal tuberculosis, which is a type of intestinal tuberculosis. It is the most common site of abdominal tuberculosis, that is, the ileocecal junction is the most common site of abdominal tuberculosis, and the most common organism causing abdominal tuberculosis, particularly intestinal tuberculosis, is Mycobacterium tuberculosis. So, it is an acid-fast bacilli. We will be discussing more on that as we come to the investigation part. Like I said earlier, Mycobacterium bovi is also known to cause ileocecal tuberculosis. You can have ileocecal tuberculosis occurring either by direct, wherein you ingest food materials contaminated by the mycobacteria, or by hematogenous route, which is as a part of a miliary tuberculosis. Mycobacterium avium is also known to cause ileocecal tuberculosis by a lymphatic spread. So, like I had mentioned earlier, among the different types of ileocecal tuberculosis, ulcerative type is the most common. It forms 60% of cases of ileocecal tuberculosis, and the name itself is self-explanatory. So, it is characterized by the presence of circumferential transverse ulcers, as you can see here. This is a diagrammatic representation, and this here is a gross specimen showing this type of ulceration. These ulcers are typically multiple in nature and they are called girdle ulcers, and they are characterized by presence of normal mucosa in between. So, you have multiple ulcers with normal mucosa in between. So, hence they are called skip lesions. Once this ulcer occurs, any ulcer tends to heal with fibrosis, or any wound as a matter of fact heals by fibrosis. So, this here causes a fibroblastic reaction and there is dense fibrosis occurring, resulting in stricture formation, and these strictures are classically called napkin ring strictures. And ulcerative type is characterized by nodal involvement and there will be extensive bowel adhesions, particularly if these ulcers become transmural. Hyperplastic type. So, hyperplastic type, like I mentioned earlier, even in the ulcerative type, there will be a certain degree of fibrosis going on. In hyperplastic type, this fibrotic reaction is taken to another level. So, there is increased fibroblastic reaction resulting in thickening of bowel wall. So, this is actually palpable from the outside as a mass in the right iliac fossa, which is nodular in nature. Now, generally, hyperplastic variant of ileocecal tuberculosis occurs in well-nourished, immunocompetent individuals, and it is less virulent. And the classical area of the intestine involved, among the ileum and cecum, it is cecum which is more commonly involved by the hyperplastic variant. Caseation in this case is very uncommon, and generally the mode by which you get hyperplastic type of ileocecal tuberculosis is primary, by ingestion of food particles which are contaminated by the Mycobacterium. Now, clinical features of ileocecal tuberculosis. So, typically the patient presents with an abdominal pain which is non-specific, or sometimes it might be localized to the right lower abdomen. Commonly it is seen in individuals between 25 to 50 years of age, and usually when the person presents to the clinician, they tend to have anemia, loss of weight and loss of appetite, which are basically constitutional symptoms of tuberculosis. Diarrhea is known to occur in 10 to 20% cases, along with fever, which is low grade fever, in 50 to 70% cases. Now, like I said, the hyperplastic type of ileocecal tuberculosis can present as a mass in the right iliac fossa, which is hard, nodular, and nodular, which does not move, which is immobile or fixed with no skin involvement. So, when you have such a mass in the right iliac fossa, it is one of the most important differential diagnoses for a carcinoma cecum or for an actinomycosis involving the ileocecal junction. So, the differential diagnosis for a right iliac fossa mass, common three differential diagnoses with relation to the bowel would be ileocecal tuberculosis, cecal carcinoma, adenocarcinoma, and the actinomycosis involving the ileocecal junction. So, these three should be kept in mind when we want to discuss regarding any bowel pathology presenting as a mass in the right iliac fossa. Of course, you can have other causes for a right iliac fossa mass, but with regard to a bowel, these are the three important differential diagnoses for a mass in the right iliac fossa. It can be associated with an adenocarcinoma of the cecum, which is very important in fact. So, just because a person has an ileocecal tuberculosis and there is a mass, it may not always be right to attribute that mass in all cases to an ileocecal tuberculosis. It can be an association with an adenocarcinoma of the cecum. And also, of course, like I said earlier, other immunosuppressed states can be associated with an ileocecal tuberculosis like a HIV. When you have a large mass which is in the RIF with dense adhesions, it can cause a small bowel obstruction. So, intestinal obstruction is also a mode by which a person presents to a clinician. Now, investigations to diagnose ileocecal tuberculosis. So, ileocecal tuberculosis, it is very important to first find out whether the patient has tuberculosis or not. Second, to localize the area of the bowel which is involved. Now, we need to identify, usually you can have a primary pulmonary foci from which the person might have developed a ileocecal tuberculosis. So, this primary pulmonary foci can be identified by a chest X-ray. As we can see here, we can see a consolidation involving the right upper zone with a hilar node here, which is usually a feature of a tuberculosis. A Mantoux test can be done. Now, it is a very non-specific test in the sense that most of the individuals who are exposed to the tubercular bacilli will turn out to be mantle-positive. So you find that even though presence of mantle-positivity indicates exposure to Mycobacterium tuberculosis, it may not always mean that the patient is having an active disease. So generally what is administered is a PPA, or a purified protein antigen, which is administered, and you look for a delayed hypersensitivity reaction, usually after 48 hours, and then we measure the wheal which occurs to say if it is significant or not. Now, a mantle-positive person should always be followed up with other tests to confirm the presence of active tuberculosis. So one of the other tests which can be done to confirm the presence of tuberculosis would be a ELISA, which is an enzyme-linked immunosorbent assay. You can look for the interferon levels using an ELISA technique. You can use a PCR technique, which is a polymerase chain reaction by which you amplify the mycobacterial DNA so that it is detectable. In fact, by PCR, you can detect 1 to 2 microorganisms or mycobacteria can be detected, or up to 8 femtograms of mycobacterial DNA can be detected within PCR, polymerase chain reaction. Now a modality which is now being used extensively in the identification of mycobacterium is CBNAT. So CBNAT stands for cartridge-based nucleic acid amplification test. It's like a rapid test to detect the presence of amplified mycobacterial DNA. An ESR can also be done, which will be elevated since a mycobacterial infection is a chronic illness. A plain X-ray abdomen can be taken, especially if you are suspecting the presence of any intestinal obstruction, as you can see in this X-ray here. So in this X-ray, you can see there is extensive bowel dilatation with valvulae conniventus visualized, which is indicator of dilated jejunal loops, indicating a small bowel obstruction. Okay. An ultrasound abdomen can also be taken, which ultrasound abdomen will be able to demonstrate the presence of bowel thickening more than 15 millimeters. You can look for thickening of the cecum, look for dilated bowel loops. You can look for radiation of bowel loops from the root of mesentery, which is called stellate sign. So all these are features in an ultrasound abdomen which point towards the presence of an ileocecal tuberculosis or an abdominal tuberculosis in general. Now, you can adopt different staining techniques to demonstrate the mycobacterium. So, one technique by one important step that is taken is you can either demonstrate the mycobacterium by direct visualization, or you can look for indicators of the mycobacterium. So, direct visualization of the mycobacterium as such can be brought about or can be aided or can be done by the following techniques. So, you can use what is called as a Ziel-Nielsen stain microscopy, which is to document the presence of an acid-fast bacilli. So, in Ziel-Nielsen staining, what is done is that initially the smear or the sample that is obtained is washed with carbol fusin. Subsequently, what is done is that it is washed and then it is denatured by using 20% sulfuric acid. Then again it is subjected to 95% ethanol, and then restaining of it is done by using either picric acid, or you can use Loeffler's methylene blue, or you can use malachite green. So these three can be used to restain the smear, and once we restain it, we can identify the presence of the acid-fast bacilli as red rods. So reddish rods. So this is what is called as a Ziel-Nielsen staining technique to demonstrate the acid-fast bacilli. Now, you can grow mycobacterium in only a specific culture medium, which is called as a Lowenstein-Jensen culture medium. So, Lowenstein-Jensen culture medium, it requires at least 100 acid-fast bacilli per ml for it to be positive. It takes 8 weeks for the culture to show the presence of mycobacterium, but it has a specificity of 90% and a sensitivity of around 80%. Now, that has been upgraded further by doing what is called as a backtech. So, a backtech can give you a result within 2 to 6 weeks, which is 2 weeks less than your Lowenstein-Jensen medium. And the number of acid-fast bacilli required to produce a growth in a backtech broth culture is only 10. It has a very high sensitivity of 94% and a specificity of 92%. So, backtech MGIT is nothing but backtech mycobacterium growth indicator tube. Okay, it uses a Middlebrook broth, which is used, and this Middlebrook broth is used, in which it is mycobacterium is cultured, and the cultured rate, the amount of bacilli required to culture is very little, and also the time taken for positivity is also less when compared to Lowenstein-Jensen medium. Now, further advancing on the BACTEC culture is to do what is called as a Cobas-Starkman PCR, wherein you require only less than 10 acid-fast bacilli per ml of specimen, and you get the report within 1 or 2 days, and it has a very high sensitivity of 97% and a specificity of 99%. Now, so after plain X-ray, if the plain X-ray does not show any evidence of intestinal obstruction, we can proceed towards a contrast study. So the most common contrast study which is done is a barium study. And in a barium study, there are certain indicators which can point towards an ileocecal tuberculosis. For example, you can have a pulled up cecum, as you can see here. You can have a pulled up cecum, and you can have an alteration in the ileocecal angle. Normally, this angle is acute. It can be obtuse in the case of an ileocecal tuberculosis, and sometimes there can be straightening of the ileocecal angle, which is called as a gooseneck deformity. As a consequence of inflammation, fibrosis, there will be narrowing of lumen of the small bowel or the ileum, resulting in what is called as a string sign. Now, there is also another sign called as a Sterlin sign. So, Sterlin sign is characterized by hurrying of the barium due to rapid flow as it passes through the inflamed bowel. So, as the barium passes through the inflamed bowel, it just hurries through it. So, as a result, the inflamed bowel will not contain any barium within it. So, this is called as a Sterlin sign. So, then you can have what is called as a Fleschner's sign, which is also called an inverted umbrella sign. So, here what happens is that you have a ileocecal junction which is thickened, ileocecal valve which is thickened, and a narrow ileum, resulting in what looks like an inverted umbrella. Calcifications can occur, especially if you have chronic infection, chronic long-standing ileocecal tuberculosis. You can have calcifications. Incompetent valves might be noted, and napkin lesions, which are basically strictures involving the ileum. So, once you have a stricture involving the ileum, it obviously indirectly manifests as what is called as a string sign. Now, megaileum. Sometimes what happens is when you have a stricture, the area of ileum which is proximal to the stricture tends to get dilated, and this dilated, grossly dilated ileum is what is called as a megaileum. So, other investigations which can be done in tuberculosis would be to go ahead with a colonoscopy. So, the colonoscopy has the advantage that we can directly visualize the mucosa, look for the presence of ulcerative changes, probably take a biopsy as well. So, this here shows the presence, is the colonoscopic finding of a patient with an ileocecal tuberculosis showing ulcerations and inflammations involving the mucosa. A capsule endoscopy can also be done, which can show us not only the presence of an ileocecal tuberculosis, but even if you have skip lesions involving the small bowel, say the proximal ileum, the jejunum, all these involvement can be identified with a capsule endoscopy. Now, generally, it is to be remembered that the stomach, duodenum and the jejunum are not commonly affected by tuberculosis. It doesn't mean that they cannot get affected, but they are not very commonly affected, especially the stomach, because stomach's acidic pH is not a suitable environment for the growth of mycobacterium. So, the stomach, duodenum and the jejunum are rarely affected by tuberculosis compared to the ileum and the colon, and you can also have tuberculosis of the esophagus. So, a capsule endoscopy can help us in identifying lesions which can involve the other areas of the bowel. A laparoscopy, yes, you can do a laparoscopy or a diagnostic laparoscopy which can demonstrate the presence of, say, a thickening involving the distal terminal ileum, inflammation involving the ileum, adhesions involving the ileum, free fluid in the abdomen. It can look for tubercles as well sometimes, nodes in the mesentery. All these can be identified using a laparoscopy. In fact, we can do what is called as a peritonioscopy, wherein only a small incision is made and a peritonioscope or a scope with a camera is inserted inside, and under its guidance we can not only look for the presence of lesions, but we can also perform small aspirations of ascitic fluid or a biopsy, etc. can be done under peritonioscopic guidance. Abdominal CT scan, yes, of course, a CECT of the abdomen with an oral contrast will give us a very good idea regarding the lumen and the presence of any changes involving the lumen, surrounding omental changes, nodal changes, free fluid, etc. can be greatly visualized with an CECT abdomen with an oral contrast. So this here is showing the presence of a thickening of involving the IC junction or the IC valve region. Now, a PCR of the endoscopically biopsy tissue. Like I said earlier, polymerase chain reaction of the biopsy tissue or the specimen or this fluid which has been got can as a very good technique by which you can isolate the organism. So it functions by increasing or amplifying the mycobacterial DNA. So even 1 to 2 mycobacterium, like I said earlier, can be identified with the PCR or up to within 8 femtolograms. So up to 8 femtograms. So even if the amount of the mycobacterial DNA is 8 femtograms, you can actually detect it. It can be detected by a PCR. So anything more than 8 femtograms will certainly be detected by a PCR. So a PCR or a polymerase chain reaction assay is a very important tool to diagnose the presence of mycobacteria in a biopsy tissue or an aspirated fluid. Stool culture for AFB is not recommended because in the sense that it is not specific. Just because there are mycobacteria in the stools, it does not mean that the patient is having an active disease. So hence stool culture for AFB is not routinely done. We can go for a blind percutaneous needle peritoneal biopsy. It can be done, or you can do it under peritoneoscopic guidance like I said earlier. Anti-cord antibody is generally done to differentiate a disseminated tuberculosis involving the entire intestine from a Crohn's disease. ADA levels, adenosine deaminase assay, can be done in the fluid which has been aspirated from the abdomen. It has a 95% sensitivity. You can look for it in the fluid or you can look for it in the serum. So if your fluid levels or ascitic fluid levels of ADA is more than 33 international units per liter, it is significant. And its levels in the serum, if it is more than 42 international units per liter, it is again significant. So this here is an MR enterography, which is showing the presence of a thickening involving the IC region and the cecum. It's a capsule endoscopic image like I said earlier. The complications of ileocecal tuberculosis are an obstruction like we had seen the x-rays earlier. Hemorrhage can occur as it erodes into the wall of the bowel. Malabsorption because it causes villus atrophy. And disseminated tuberculosis can occur with the nidus being in the abdomen. Can have a cold abscess formation, especially if there is mesenteric nodal involvement. The nodes in the mesentery can get caseated or can have a cold abscess formation. Fecal fistula, yes, it is notorious to cause fecal fistula, especially if you have intervened surgically in a case of a tuberculous abdomen. The chance of fecal fistula is very high. And a perforation can obviously occur if the involvement is transmural. Now, the treatment of tuberculosis is primarily medical. So only if you have certain complications do we go ahead with the surgical management. So the medical management of tuberculosis is essentially with anti-tubercular drugs. And the 4 most commonly used anti-tubercular drugs are isoniazid, which is given at the dosage of 5 mg per kilogram body weight, rifampicin, which is given at the dosage of 10 mg per kilogram body weight, ethambutol, which is given at the dosage of 15 mg per kilogram body weight, and pyrazinamide, which is given at a dosage of 25 mg per kilogram body weight. Now, there are other alternative drugs which can be used if there is resistance to these 4 drugs. For example, like you can use rifampicin, clarithromycin, azithromycin, ofloxacin, ciprofloxacin. So all these are other drugs, kanamycin, all these are other drugs which can be used in the event of a resistance to the 4 major drugs. Now, the general dictum is that we treat any case of tuberculosis for a period of 6 months if it is uncomplicated. So an uncomplicated tuberculosis case is treated with 4 drugs for 2 months and 2 drugs for 4 months. If it is a case of complicated tuberculosis, then the duration of treatment can go up to 11 months. But with regard to abdominal tuberculosis, we generally prefer if the duration of anti-tubercular therapy is for at least 1 year. Now, it is to be remembered that a person with abdominal tuberculosis can develop complications such as strictures, obstructions while on treatment with ATT. So, this complication can occur by around 3 to 6 weeks after the treatment has been started in the form of drugs. So this is because the healing of the ulcers tend to occur, and these heal with fibrosis causing stricture formation. So a patient who's on ATT can develop an adhesive obstruction or an obstruction subsequent, a small bowel obstruction 3 to 6 weeks after initiation of therapy. And you should remember that a person who's having abdominal tuberculosis is likely to be malnourished, so hence requires nutritional support along with the drugs which are being provided. And moreover, these drugs can have severe side effects associated with it, should also be taken care of as the patient is being treated. Now, role of steroids. Yes, there is certainly a role of steroids in the management of Mycobacterium tuberculosis. So it can be used in the management or in the treatment of biliary tuberculosis, tuberculous meningitis, adrenal tuberculosis, tuberculous pericarditis, ocular tuberculosis, and genitourinary tuberculosis. It can sometimes be used in mediastinal tuberculosis if it is rapidly progressive. Now, so while the patient is on medical management, he might require a surgery, like I said earlier. So there are only specific options, or there are specific indications for surgery in tuberculosis, abdominal tuberculosis, and these indications are intestinal obstruction, severe hemorrhage, perforation, abscess formation and fistula formation, and when you have no idea regarding what is the diagnosis of the patient. So these are the various indications to proceed with the surgery in a patient with abdominal tuberculosis. So what are the surgical options that are available when you operate on a patient with ileocecal tuberculosis? So we can go for a limited ileocecal resection, wherein we remove the distal ileocecal, terminal ileum, ileocecal junction, the cecum and a portion of the ascending colon, okay, giving a margin of 5 centimeters on either side, the proximal and the distal ends, so that healthy bowel can be anastomosed. So generally an anastomosis is always preferred in a case of ileocecal tuberculosis after resecting to healthy margins. So if you have healthy margins, the patient does not have bowel which is very friable or like grossly diseased, we can always plan for an anastomosis. So what happens if you enter inside and you find that the patient has an ileal stricture? Now, if the patient has a single ileal stricture, a short segment stricture, we can always go for a strictureplasty. So imagine the bowel is strictured. So this is a stricture, right? So you can have an incision is made longitudinally, and this longitudinal incision that is made full thickness is closed transversely so that the stricture gets mitigated. So the lumen continuity is maintained and the lumen patency is maintained. So strictureplasty can be done in the case of a single ileal stricture. Now, suppose you have multiple ileal strictures. If you have multiple ileal strictures within short distance of each other, we can go for a resection of the entire segment which is stricturous. All these stricture segments can be resected and you can go for an anastomosis. Suppose you have strictures which have extensive normal bowel in between them. Suppose you have a stricture near the IC junction and you have another stricture about 20 centimeters from the previous stricture. You cannot waste normal bowel or resect normal bowel. So in such cases, we can go for strictureplasty or strictureplasty in each of these sites. Suppose you have a long stricture, a long extensive stricture, it is always better to go for a resection and anastomosis. Okay. Now, suppose you have a perforation. A perforation, we have the option of closing the perforation or doing a resection anastomosis. So what determines whether we close the perforation or do a resection anastomosis? It is the nature of the bowel which has perforated. If that bowel which has perforated has healthy margins, is not grossly diseased, and there is no distal obstruction, we can go for a primary closure and the perforated edges can be sent for biopsy. If you find that the bowel is grossly diseased and there is a distal obstruction, we can always go for a resection of the segment and an anastomosis. Now, if you have extensive adhesions involving the bowel, secondary to abdominal tuberculosis, intestinal tuberculosis, we can always go for a laparoscopic adhesiolysis. It is very difficult, but it can be done. Now, if the patient is having an abscess, intra-abdominal abscess, or a perineal abscess, or a fistula nino, etc., we can go ahead with drainage of the abscess or excision of the fistula, etc. Now, there are certain contraindications to performing a strictureplasty. Now, if you have extensive, like I said earlier, if you have a tension at the level of the if they have an extensive tension due to rigid or thickened bowel segments, if the bowel segments are diseased extensively, you don't go for a strictureplasty. If there's a perforation in intestine, obviously you wouldn't go for a strictureplasty. If there's a fistula or an abscess formation at the intended strictureplasty site, again, we don't go for strictureplasty. Hemorrhagic strictures, no strictureplasty. Malnourished and hypoalbuminemic patients, again, are not candidates for strictureplasty. If you have a suspicion of a malignancy at the intended strictureplasty site, again, do not proceed with it. So this here again is a diagrammatic representation of what I said earlier. So this short segment stricture here is incised longitudinally. The cut edges are then closed transversely, so has to ensure lumen patency. So that is one option. Another option is what can be done is the incision is made longitudinally and the bowel is folded on itself and it's anastomosed. So that is another method by which a strictureplasty can be done. So this is a Heenick-Mechelick method. What is described here is a Heenick-Mechelick method of a strictureplasty. Now, the specimen that is resected is always sent for histopathology, and on histopathological examination, we look for the telltale features of tuberculosis. So this here is a granuloma which is seen typically in tuberculosis. And in a granuloma involving the tuberculosis, we tend to have areas of case-shading necrosis as well as giant cells, Langhans giant cells, epithelioid cells and fibroblasts, all of which can be seen in this slide here. So with this, we can come to a conclusion that the patient is having tuberculosis. Now, these specimens which have been obtained can also be subjected to PCR and other techniques which will be more sensitive in detecting. But what I have described here is a histopathological examination of a specimen taken from the histopathological examination of a specimen which has been obtained from an operative procedure. Now, ileal tuberculosis only. So you can have an ileal tuberculosis solely without involving the IC junction or the cecum. Now, generally, ileum and the IC junction, why is it more commonly involved in tuberculosis? It is because of an IC valve. Because there's an IC junction and IC valve, there is stasis of material within that region. So this infected material which is stased, and because there are a lot of Peyer's patches, get taken up by the bowel into the wall. And then the disease process further induces an inflammatory response and it progresses towards its changes that you can see here. So the IC junction leading on to stasis, presence of Peyer's patches, the liquid nature of the contents at that level, pH of the contents at that level, all these seem to influence the occurrence of Mycobacterium tuberculosis infection in the ileum and particularly in the terminal ileum. So ileal tuberculosis per se, solitary ileal tuberculosis can be single or multiple in the sign of fact that ileal tuberculosis you can have multiple segments of ileum which is involved, or you can have a single segment of ileum which is involved. Commonly it presents with bowel obstruction. Perforations are extremely rare. And when you have a bowel obstruction, obviously the X-ray will show multiple air fluid levels, especially if it is taken as an erect X-ray. And the treatment is to proceed with a resection anastomosis, so ensuring that the edges which are anastomosed are healthy. It should be supplemented with an anti-tubercular drug therapy. Strictureplasty, like I said earlier, can be done if you have a short segment stricture. Yeah, you can proceed with a strictureplasty in ileal tuberculosis. Peritoneal tuberculosis. Now, peritoneal tuberculosis is characterized by presence of thickening and fibrosis involving the peritoneal wall. And there are multiple tubercles noted all over the peritoneal wall and as well as on the solid organs in the peritoneal cavity. It can be a wet type wherein you have extensive ascites seen in 95% cases, or it can be a dry type wherein there is fibrosis and adhesions presenting as a cocoon. The occurrence of a peritoneal tuberculosis, the mode by which it occurs, it can either be blood spread, or it can be retrograde spread via the fallopian tubes in females. Now, based on how they present, how a patient with peritoneal tuberculosis presents, you can have different types of it. So, you can have an acute type wherein the patient presents with peritonitis features. So, while suspecting a peritonitis, when you open the abdomen, you find there will be a straw-colored free fluid, extensive tubercles. You can have a rupture or a perforated mesenteric node, mesenteric tuberculous lymph node. And when you evacuate the fluid, you can take a biopsy and send the ascitic fluid for analysis, you'll be able to prove the presence of tuberculosis. Generally, no drain is kept because of fear of a fistula formation, and generally such individuals tend to have a burst abdomen more commonly than the others, and hence TENS and sutures should be considered in these individuals. Chronic tuberculous peritonitis. Now, a patient with chronic tuberculous peritonitis will classically present with non-specific abdomen pain, fever, loss of weight, appetite, and with ascites. And on palpation, in 10% cases, they can have a doughy abdomen. The omentum in chronic tuberculous peritonitis will be thickened and rolled up. And you find that this chronic tuberculous peritonitis can occur from lymphatic spirit as well. Laparoscopy is useful to diagnose chronic tuberculous peritonitis. Ascitic forms. So, as the name indicates, a patient with ascitic form of peritoneal tuberculosis has cross abdomen distension because of ascites. They tend to have an umbilical hernia or a hydrocele because of the rise in intra-abdominal pressures. Shifting dullness of fluid thrill might be positive, and they can also present as a mass in the abdomen. When you do an ascitic tap, you will more or less be able to diagnose the presence of tuberculosis. These individuals with ascitic form of peritoneal tuberculosis will require ATT for a period of at least 1 year. Now, there is a role for repeated tapping if the patient is having increasing abdomen distension. Otherwise, it should settle with antitubercular therapy. Now, loculated ascites. So, localized or loculated ascites is because of fibrinous deposition within the peritoneal cavity, which limits the ascitic fluid to one particular area, as you can see here. Here, dullness may not be shifting because it is fixed to one area. There might be a palpable mass present. So, here you cannot blindly go ahead and aspirate the ascitic fluid. You have to go for an ultrasound guided aspiration, and that will give us a clue regarding the presence of tuberculosis, and subsequently we can start the patient on ATT. The other forms are plastic form, wherein you have extensive adhesions like a cocoon. A purulent form, wherein you have tuberculous salpingitis, which presents a mass in the lower abdomen. There is subsequently a caseating small mass or a cold abscess formation, which communicates with the umbilicus, forming an umbilical fistula. This is commonly associated with genitourinary tuberculosis. An ultrasound abdomen as well as a discharge study, which is coming from the discharge study of the discharge coming from the umbilicus, will give us a clue regarding the presence of tuberculosis. ATT has to be started like in any case of tuberculosis, plus or minus an umbilical exploration. The problem is such forms of purulent peritoneal tuberculosis, the prognosis is said to be poor. Now, this is a condensed tabular column of the various features of the different types of peritoneal tuberculosis: the ascitic form, the fibrous form, the purulent form, and the loculated form. So, the evaluation of a patient with peritoneal tuberculosis includes taking a chest X-ray to look for a nidus in the chest. An ultrasound and a CT abdomen can give us an idea regarding the presence of free fluid, peritoneal deposits, rolled up omentum, bowel thickening, bowel adhesions, etc. Ascitic fluid analysis can be sent to document the presence of acid-fast bacilli. A diagnostic lab can be done again to take a biopsy, an omental biopsy or a peritoneal biopsy, or you can aspirate the ascitic fluid as well by diag lab. The ascitic fluid that is aspirated in such cases is subjected to analysis. So, if you have a serum ascitic albumin gradient of less than 1.1 gram per deciliter, we think in terms of a tuberculous ascites. If the ascitic fluid by blood glucose ratio is less than 0.96, or if the lymphocyte levels in the ascitic fluid is more than 1000, sometimes it can be as high as 4000 cells per cubic millimeter, then you should again suspect the presence of tuberculosis. AFP positivity in ascitic fluid is seen only in 3% cases. General culture, a Lowenstein-Jensen medium, and as a culture medium for AFP or mycobacteria, you find that its sensitivity is only 20%. If you centrifuge the ascitic fluid and then subject it to a culture, you can detect acid-fast bacilli in as many as 80% cases. Adenosine deaminase levels can also be looked for in the ascitic fluid. If it is more than 33 international units per liter, again, is likely to be significant. And is likely to be tuberculosis. Ascitic fluid to serum ADA ratio, again, if it is more than 0.985, again it points towards the presence of peritoneal tuberculosis. Gamma interferon levels can also be looked for, and you can also look for other markers, for example, elevated levels of protein in the ascitic fluid, a pH in the ascitic fluid can be looked for, a specific gravity of the ascitic fluid can also be checked. So, all these are different other tests that the ascitic fluid can be subjected to, which can aid in the diagnosis of tuberculosis. The treatment of a peritoneal tuberculosis patient is the same. You have to start the patient on ATT. Surgery is indicated only if you have intestinal obstruction. Tuberculous mesenteric adenitis. Now, tuberculous mesenteric adenitis occurs basically because of hypertrophy of the Peyer's patches. And the common mode by which these Peyer's patch gets hypertrophy is by oral ingestion of food which is contaminated or material which is contaminated by mycobacteria. The nodes which are involved, mesenteric nodes which are involved, are commonly on the right side, but of course left side nodes can also get involved. Children are most commonly affected by tuberculous mesenteric adenitis. They are typically present with constitutional symptoms along with right lower abdominal pain or an RIF pain as it's called. Because they tend to present with RIF pain, right lower abdominal pain, they tend to mimic, this condition tends to mimic acute appendicitis. When you have a mesenteric node which is enlarged, it can caseate, can rupture. So, through these ruptured mesenteric nodes, you can have bowel going and getting adherent, causing adhesive obstruction. Sometimes you can have large nodes in the mesentery, tuberculous nodes in the mesentery, which is called as Tabes mesenterica. A mesenteric node can sometimes caseate and form a cold abscess between the layers of the mesentery. So, this is what is called as a pseudo-mesenteric cyst. So, of course, it's a very important differential diagnosis to a classical mesenteric cyst. So, the investigations which can help us in the diagnosis of a tuberculous mesenteric adenitis are an X-ray abdomen, an ultrasound abdomen, and of course, a diagnostic laparoscopy. Sometimes in children, we can get non-specific mesenteric adenitis, which is called as nurse's disease, and hence it is very important to differentiate such non-specific mesenteric adenitis from tuberculous mesenteric adenitis. The treatment of a tuberculous mesenteric adenitis is with antitubercular therapy, and the prognosis is generally good. Anorectosigmoid tuberculosis. Patients with anorectosigmoid tuberculosis classically present with hematochezia. They can also have constipation, tenesmus. Sometimes they can also have diarrhea, spurious diarrhea occurring. Multiple discharging fistulas can be noted in the perianal region. The lesions are typically located within 10 centimeters from the anal verge. They generally present as fistulas, like I said earlier, multiple painful fistulas which are non-indurated. So, presence of perianal fistulas which are non-indurated, you should always think of the presence of a tuberculous fistula. Anal ulcers can also be a manifestation of an anorectosigmoid tuberculosis. These anal ulcers classically are bluish in nature and have undermined edges. A very important differential diagnosis to an anorectosigmoidal tuberculosis is a rectal carcinoma. A sigmoidoscopy, discharge study, a biopsy from the lesion can help us in differentiating anorectosigmoid tuberculosis from a rectal carcinoma. And the treatment of a tuberculosis, such type of tuberculosis, is with ATT along with a fistulectomy if the patient is having a fistula. Now, just performing a fistulectomy in a patient with anorectosigmoid tuberculosis is actually not useful at all because they can have a very high incidence of recurrence. Omental tuberculosis. So, omental tuberculosis is generally a part of other types of tuberculosis. So, here classically the omentum is rolled up with thickening and they can have a cold abscess formation within the omentum. The treatment of such cases of omental tuberculosis is with ATT plus or minus a laparoscopic management in the form of an omentectomy, or if there is an abscess, it can be drained. Now, once you start treatment of a patient with abdominal tuberculosis, how will you follow up such a patient, or what do you look for on follow-up? So, a patient who is on follow-up with antitubercular therapy should always be assessed for weight gain. See if the patient is gaining weight. Is there an improvement in the constitutional symptoms such as loss of weight, loss of appetite? So, is there an increase in appetite in the patient? Is there a reduction in abdominal symptoms like pain, distension, vomiting, all these? If there's a, to check if there is a reduction of abdominal symptoms. And an ultrasound guided assessment can also be done to look for improvement, disease improvement. Now, like I said earlier, patients with abdominal tuberculosis, particularly intestinal tuberculosis, particularly ileocecal tuberculosis, can present with small bowel obstruction 3 to 6 weeks after initiating anti-tubercular therapy because of strictures. So, hence, patients who have been started on anti-tubercular therapy should be kept on strict follow-up and should be asked to review immediately in case of abdomen distension and vomiting. It could be a small bowel obstruction. If you find there is no response, even after 6 weeks of starting the patient on anti-tubercular therapy, you should assess for the presence of drug resistance as well as with the presence of associated diseases like malignancies, inflammatory bowel diseases like Crohn's. You should always look for the presence of such disease conditions. So, with this, we come to the end of this topic on abdominal tuberculosis. The slides that content which have been enumerated in these slides have been taken from Bailey and Lau textbook of general surgery as well as from SRB textbook of surgery and from Sebastian textbook of surgery. So, until we meet the next time, thank you.